Good afternoon, everyone, and welcome to today's webinar, Hospice Readiness for Hope, Practical Steps to Take this Spring. My name is Catherine Deline, and I will be your facilitator for this session. We are thrilled to have you here as we explore the latest updates on the Hospice Outcomes and Patient Evaluation Model, also known as HOPE, and discuss actionable steps to prepare you for its implementation. Before we dive in, a few quick notes. Each registered participant should have received a link to today's slides in your inbox. It was probably about an hour ago. So if you didn't receive it, check your spam or reach out to us. We'll make sure you get a copy. We'll be sharing an email address at the end of the presentation so that you can let us know. Now, this webinar is being recorded, and we'll share the recording with all registered participants after the session. You will be auto muted. So if you have questions during the session, please submit them through the Q&A box that you'll see at the bottom of your screen. Now, if we don't get to them live today, we will respond via email in the days following the session. We'd also like to take a moment to thank our sponsors, Confidence Consulting and HospiCore, for making this webinar possible. Their commitment to innovation and to quality in the hospice industry helps drive important conversations just like the one we're having today. So without further ado, I'm excited to introduce our incredible panel of experts with us today, each bringing their own unique insights into HOPE and the readiness and implementation for organizations. So in order of presentation, we will start with Ms. Judi Lund Person. Judi began her career in 1980 as the executive director of North Carolina, which became the Carolinas Center for Hospice and End-of-Life Care. In 1981, she joined other passionate hospice advocates to successfully lobby for the passage of the Medicare hospice benefit in Congress. And she worked to prepare recommendations for the original Medicare hospice conditions of participation in '83, and again in the major revisions of 2008, as well as participating in the negotiated rulemaking for the Hospice Wage Index. Judi has been involved in the implementation of the Hospice Act with CMS, including surveyor training, enforcement remedies, and the Hospice Special Focus Program. She's also presented hospice and palliative care with the Medicare Administrative Contractors, what we know as the MACs, addressing confusion about attending physicians, claims processing, and hospice payment policy issues. Judi spent over 20 years as a VP of Regulatory and Compliance at the National Hospice and Palliative Care Organization. And there she oversaw hospice payment policy, Part D, surveys, certification, contractor management, and program integrity. Amazing. Next, we have Donnette Threats. Donnette brings over 30 years of experience in the hospice industry. She has led executive positions in both hospice operations and software development, making her uniquely positioned to bridge the gap between the clinical needs and electronic medical record technology. With extensive expertise in the hospice industry and in operations, regulatory compliance, and quality and performance improvement programming, she offers valuable insights into how EMR systems can support HOPE implementation and compliance. So we're really eager to hear what she has to say. And last but certainly not least, Ms. Carla Braveman. Carla is a registered nurse in the state of New York and has more than 35 years of operational experience in clinical and executive positions within home health, hospice, and palliative care. Having worked in both nonprofit and for-profit sectors, Carla combines efficiency and productivity expertise with a passion for the mission of nonprofit providers. She's led multiple post-acute provider turnaround situations, improving margins, and leading culture change for staff. Carla has held executive roles across home health and hospice, including clinical director, VP of clinical services, COO, and CEO. She has also served as VP of post-acute care for a hospital-based system and as CEO president of the Hospice and Palliative Care Association of New York State, bringing deep expertise in leadership and care delivery. Carla has served multiple terms on the board of the National Association for Home Care contributed to CMS Medicare committees and NHPCO committees in regulatory, quality, and education capacities. She's chaired hospice and palliative care organizations in New Hampshire, Florida, and Massachusetts, and chaired the Hospice Association of America. Gosh, thank you all for joining us today. Truly, we are in for a treat. With that, let's dive in. Judi, I'll turn it over to you to kick us off.
Thank you so much, Kat. We are all of us are so glad to be here. And we will we'll just go ahead and get started. So let's start by taking a look at what CMS says the purpose of HOPE is. And I think I'm going to highlight a couple of things that should be raising our antenna a bit, because we want to make sure that we are thinking way ahead of where HOPE is right this second. So obviously, assessment-based quality data, better understanding of patient care needs. And you can read, I won't read it for you, but I want to emphasize this one right here. The provide additional clinical data to inform, like red flag, please, future payment refinements. This is going to be a really important part of the reason we got started with HOPE in the first place. So I want us to think about HOPE not only as really improving our quality of care, really gathering more data, but also what could this mean for us as hospices into the future? So just a quick timeline. We've been working on HOPE for many years, CMS has, and the final rule came out in the FY25 Hospice Wage Index, which was last summer. So we've got the guidance manuals, we've got all the, well, we say here that the HOPE data specifications were posted in September of last year. That's true. But what we don't see here is the draft HOPE data specifications. So Donnette will tell us a little bit more about that. One of the things I think we find really encouraging is that there is a lot of information about HOPE on the CMS website. And so a lot of folks are doing webinars. We want to make sure that we are providing you with new and interesting information, but you also have ways that you can go to the website as well. So a couple of things that are, I think, important about this. There are 4 elements to HOPE, the admission or assessment visit, and then 2 what they now call HOPE update visits, or HUVs. One between days 6 and 15, and the second one between days 16 and 30. And then finally, a discharge visit as well, or discharge entry. Now, the other thing I think that is going to be really, it's probably part of the challenge of trying to figure out how to implement HOPE, are these symptom follow-up visits. So this is patient determined if they report moderate or severe pain or non-pain symptoms, and we'll talk, Carla will spend time talking about exactly what those symptoms might look like. Those visits must be done within 2 days of the initial assessment, 2 calendar days. They're separate from the HUV visits, and I don't know about you, but this last bullet, it can be done by either an RN or an LPN or LVN. That is really great news. CMS did that specifically because of the nursing shortage and the worry that many hospices were not going to be able to comply with this 2 calendar day issue unless we had a little bit more flexibility with staffing. Also in the assessment, there are expanded domains, lots of additional questions compared to what you see in the HIS today. So another way just to look at it, and we'll just keep on moving. So one of the things that CMS did early on is to put out this time points explainer video. It's about 4 minutes, maybe a little bit longer than that, but it is really helpful. And a lot of hospices that you and I all know are using this to help talk to their staffs about this upcoming hope, what that means, what that looks like, and what these time points are. And I know Carla will be talking about the really important calendar, how you schedule these, but we can start with this is really good kind of beginner piece from CMS. So just graphically, same information, and this is something that I think we're going to keep on coming back to, because we don't want you to miss any of these time points, especially the HUV visits. Recently, we asked CMS the question, what if our HUV visit is 1 day late? Or what if the symptom follow-up visit is 1 day late? And they said, please still file it, but then that lateness will count against your 90% threshold for making sure you don't get a reduction in your payment of 4%. So you see this, we really are happy that we got the clarification on both the HUV visits and on the symptom follow-up visits. All of those visits are due within 30 days of when they occur. Then this chart should be completely familiar to you. We've been following it for years. This is gather the data in calendar year 2025. Too late to get started now, but calendar year 25, that data gathering affects your 2027 annual payment update. All right, so 2 quality measures that CMS has been very pleased to be able to add to the HOPE process. One of them is the impact of pain. The other one is the non-pain symptoms. And you know this already. And here's the list. That very last bullet: shortness of breath, anxiety, nausea, vomiting, diarrhea, constipation, agitation, and other symptoms that you have collected on that assessment visit or on either of your HUV visits. And so the first place we're going to look is, this is actually a snip of the HOPE tool where you are asking about symptom impact. So I just want to call your attention to the little descriptor at the very top. Over the past 2 days, how has the patient been affected by each of the following symptoms? And so you're going to be talking to the patient about what the impact of these symptoms are for them. And then your coding is, you can see right there, 0, 1 through 3, or 9, and the code gets entered in each of these boxes. Now, what happens if it's a moderate or severe? So you rate it as a 2 or you rate it as a 3, based on what the patient is telling you about how it affects him or her. And then you're going to go to this second box, and you're going to put in, yes, a symptom follow-up visit was conducted, was completed, and here's the date. Now, there are reasons for the SFV not to be completed. You can see the 4 listed, well, the 3 really listed there. And, you know, there are 2 parts to this. One of them is the symptom follow-up visit is attached to the HUV. So if you did the HUV on time, but you missed the symptom follow-up visit, that is part of your 90% threshold miss. So just pay a lot of attention to that. Let's look a little bit more closely at these reasons. No, this is kind of what we know about, we'll get to reasons in just a moment, what we know about the symptom follow-up visits themselves. So this is different from the HUV. They start with HOPE on October 1, 2025. And I want to clarify just for a minute, the October 1, 2025 is for patients who are admitted on or after that date. No telehealth visits are allowed, no phone calls are allowed, and no public reporting. Thank goodness, we need to get ourselves used to this, until no earlier than November 2027 or FY28. Now let's look at the reasons why a patient might be excluded from some of the HOPE process. So they died or were discharged before the symptom follow-up visit was conducted. They refused. The hospice couldn't reach the patient or the caregiver. They traveled out of the service area, or they were in the hospital or ER. Now, one of the things I think we know because the spotlight is on all of us, but we know that if you said that your answer why you didn't do the symptom follow-up visit is the patient and caregiver refused. I'm just putting it out there that if that's the answer to most of the times when a symptom follow-up visit should have been done, that is really going to be a red flag for audits and for other folks to be looking at your HOPE data and saying, something isn't right here. So I just want to caution us that if that is the case, patient caregiver refuses, or really for any of these, you have the documentation to support why that was true. All right, Donnette, it's up to you now. I'm turning it over to you.
Thank you so much. Welcome, everyone. Today we're going to talk a little bit about this partnership that I know that you have with your EHR vendor, but I want to talk a little bit about intensifying that or making it a little bit stronger during this process. It is going to take a partnership to be successful at HOPE. You're going to need to work very, very closely with your EHR vendor in order to be successful in implementing whatever plans you've already established for HOPE. In order to be successful in any partnership, it's important that both participants understand the needs of the other. We probably have a really great understanding about our internal processes, but do we understand what the vendor process is? I'm going to go through that at a very high level. I'm not going to dig into details, so I'm not going to bore you with that. But I want you to understand their process so that you can communicate very effectively with them. Because right now, that's going to be your best tool, is to really communicate very effectively with your vendor. Make sure you understand what their timelines are, what they're planning, when they're planning it, and to be able to interact and provide in feedback on what's important to you in a way and in time that's going to be most beneficial. So let's talk a little bit about that. Their processes, their development process typically starts with communication. Now, the first three things on the top line, communication, requirement analysis, feasibility study, those things tend to go together, but it's important that you understand what they are separately. Communication is when they're going to reach out to you and they're going to send out a request, or somehow they're going to communicate with folks and say, hey, do you want to collaborate with us on this? It's going to be up to you to say, yes, I want to, because you're invested in what they're going to actually develop. Now, there's a little caveat with that communication. For most vendors, that communication window is probably already closed, that initial communication. When they're gathering what's important to you and they're gathering what they're going to develop, we're going to see that because all of these lead down to a planning and system analysis process, which is based on feedback they're receiving in the first three steps. But that communication is open communication. What is HOPE to you? How is it going to impact you? How is it going to impact your process? How is it going to impact the way that you document? What are you anxious about when it comes to HOPE? What would you like to see? Those are some of the questions they may ask in an open forum just to get your ideas. Then they'll begin to build their own requirement. They go to an analysis process where they're going to talk about, okay, what could HOPE look like in the software? All the requirements, of course, they're going to look at what CMS has out there, which was great. They provide the draft back in September, so everyone is working on the draft. The final is not out, and that's important for you to know, because if they're already in the planning stage, and many of them are actually in the coding stage, then the fact that they're working on a draft spec, not the final, is giving most software vendors a little bit of anxiety. Typically, CMS do not provide significant changes to that spec that late in the game, but we never know. We are all praying that they don't. And therefore, what we're working on what your vendor is communicating with you today is actually the draft specs and what they're expecting to deliver based on what they know. Not only from the draft specs, but also what was released and we're all working off, which is that document that says this is hope. These are the questions. This is when the visits are required. This is what's expected from every person that's going to submit data. There's also going to be a validation tool, which Carla will also talk a little bit more about later, but it's going to also come much later. And that's that validation tool that would probably scrub your data, tell you whether or not it's accurate, not accurate, long before you actually submit it. Be aware of the fact that the specs for that has also not been delivered, but we're anticipating that in the near future. As we go through the requirement, then we talk about feasibility study. This is when we take all the great ideas that, oh my gosh, it would be great to have, and then you start going down to the rubber and hitting the road with it and say, how real is this? What is this going to look like in this particular software? Each software is designed very differently. So what they can and will do and how they're going to do it is going to be different based on their software design. But there is this feasibility of if we're going to do this, if we're going to provide it, how is it going to look? And that will lead to the entire planning. Now, your planning is going to include not only a scope of what they're going to do, definitely the goal of the project. It may also include, and it should include, some objectives for the project so that everyone's on the same page about what's going to be delivered and making sure that you have enough resources within their shop to deliver that. Design may also occur. At this point, you may also find that your vendor is reaching out to you to look at some mock-up of what hope may look like and ask for your feedback on how you think this will work. They're not typically going all the way back to the drawing board on that because they've gone through a lot of feedback all the way up to the planning. They're asking for feedback. They're collaborating. And again, I'm going to say this, and you're going to hear it several times. Collaborate. When they ask for you to communicate, please do that. It's not okay at the end to come back and say, hey, you didn't do this, or hey, we don't like that. They've gone through this process, join them in it. And this is where you can have that opportunity to say, hey, what do you think about? Because right after that, they're going to begin coding. Most vendors have already began some level of coding. Typically, when we get down to the next piece, which is going to be the testing and actually implementation process, coding's already done. You're going to be changing and tweaking code, but you're not going to go back and try to start from the beginning. That is a heavy lift for any vendor. Test and integration. This is when they will take that product. They'll go through their own test. Their tests will be automated. Their tests may also include hands-on testing by folks they've hired to do testing. And they also will include vendors not vendors, but customers in the testing. You may have a test database depending on your software vendor where you're asking them to put code in. You're going to test it. You're going to have your end users go through, give feedback. And again, they're going to take that in. Keep in mind, we've gone through an entire process. We're almost at the end. This is not when we go back to the beginning. This is when we take what's there and make it user-friendly. Deployment and implementation is right after that. So code is ready to be deployed. This is important. It's important that you understand how your vendor is planning on deploying Hope. Hope is going to be a midnight switch. You're going to have HIS up to midnight, and after midnight, you are going to have Hope. So as a vendor, they're probably releasing code now or plan to do so in the near future in your database, which may be hidden or not active, but it's there so that they're not doing a big bang implementation, trying to get all of that out. They need to be strategic about how they're going to test it, how they're going to make sure it works, so that at midnight, following morning, 12:01, when you're now in Hope Land, you have everything that you need to be successful. And of course, there's going to be maintenance and update, which will take you right back to communication. Lots of opportunity to communicate, lots and lots and lots. But what are vendors very concerned about? They're concerned about that draft status of the spec. They're also concerned about things that we're going to talk about in the next slide, where we talk a little bit about, okay, what have you done and how's that going to impact hope? Considering, like, unlike most code where you do have time to go through your code, it's delivered in full, you test it, and then it goes live. This is different. This is a midnight transition. So you will be testing long before that midnight. Please plan on participating in any testing that your vendor is offering. I often think about software design, and I've had the pleasure of working with a few vendors, as playing Jenga. Because most of us, we are not using a software that is brand new, that was developed yesterday, and is just there for you to play with for the first time. No, it's existing. And you love that because you have all this code, you have all this big and amazing resources and features and reports and dashboards and all these things that you've been able to customize or you've been able to configure over time to meet your organization need. When you think about adding new code to that, it's kind of like playing Jenga. Not only are they looking at what they've done, they're also looking at what you may have done to that software as you have used it over time. The longer you've used the software, the most likely you have not only configured it, but you've also probably made some modification to it, which are all acceptable, but still have to be taken into thought as you move forward with implementing a tool like Hope. So what's different about Hope? Hope actually affects everything. It affects not only your documentation, but how you're going to communicate. It affects this amazing thing in all software, which is time. When are you doing something? Because if you think about it, every time a nurse goes to see a patient, the first thing they're capturing, or the one thing that they have to capture, is that time. When did I get there? Was I there for how long? All of that is time. And in software land, time is really important. It pivots a lot of different things, including billing. So as you're thinking about how you're going to implement Hope, please do not forget that it affects all aspects of your business. Don't leave your billers out of the discussion. Please don't leave your intake folks out of the discussion. Don't leave anybody in your organization out of the discussion, because Hope is going to affect everybody. Your partnership with your EMR vendor or EHR vendor should include three things: communication, and I've kind of touched on that before. Collaboration, I also touched on that, but also a commitment to work with them. And we're going to dive into these really quickly and not go too deep, because I know that Clara is going to take you a whole lot deeper than I'm going to take you. But I want to hit some things from the vendor perspective. First thing, there's some basic questions that you should ask about what your EHR vendor have in mind. But those questions should be asked after you have completed your own internal process review, because you need to be specific in asking those questions. What may matter to my hospice may not matter to your hospice at all. What will be important in my software may not impact your software at all, because of the tools and features that are already built in. So it's important that you are asking specific questions. So for instance, section A, F, and I, where are they going to be pulling this data from? Where are they going to be pulling that patient name, date of birth, all of that from? They're probably pulling it from a vital place today, but some of this information will change. And you've already looked at, I'm sure you have, as you look at the Hope document, you've seen where some of the his questions are going to change, what they're asking for nationality and race. That's going to probably change a little bit depending on your software, but it's dictated specifically what it must be for Hope. And you want to know, where is that coming from? Because that may change not just your documentation, but also where information is being documented in your system. Some of that content is actually being touched by different people within your organization. During that intake process, think about how many different people create that chart and build that chart and modify that chart before that patient is even admitted. So make sure you understand where this information is going to be captured, how often it's going to be updated within your organization, so you can communicate clearly about when that data is going to be pulled into that file that's going to be submitted to CMS. Also, for the clinical information, you also want to ask a lot of questions, lots of them, about these new visits. How are you going to know that an SFV visit is required? How is it going to be visible in the software? Is that just going to be to the clinician, or is that going to be to the back office? Will the back office be able to see it, manage it, do something related to that, just in case something happened to that clinician? All of that is information you need to know. You also need to know what's going to trigger that SFV visit in your system. Is it coming from the question? Is it coming from something else? Is it a manual thing that the clinician is going to be required to do? All of that is going to be important questions that you need to ask. You also need to understand what is going to be different for you. Is it going to matter when data is being collected? Is it being collected at midnight? Is it being collected on the weekend? Does that make a difference for the resources? And when I talk about resources, I'm primarily talking about people, the people that you have working. What is it going to look like when that change occur at midnight? What is it going to look like for your users when they are now presented with new data collection? And of course, test, and over again test. Carla has some great ideas to tell you about how to really go through this with your clinician. So I'm not going to spend a lot of time with it, but please do communicate that back to your vendors, your findings. You want to look at, who do you have? Do you have resources? When do you want to implement certain things based on the resources you have? And also, you must know your vendors' anticipated release dates. They have a lot of training occurring now. Please sign up for them. Listen, ask questions. And if you don't get your questions answered during that session, seek out someone to provide that those answers. There is a distinction between software training and training that you are going to do for your staff. Make sure that you understand those differences. Make sure your staff understand how they should ask their question, because most likely your vendor is going to create the question in the assessment tool exactly as CMS has required them to do. You must also review your data. Where are you today? And I'm just going to touch on that very high again, because we're going to talk about it again. But as you think about your data, what have you changed within your system? I know if you've had your database for a long time, you have configured that database. Not a problem with that, but know what your vendor is going to release so that you can understand what you should and should not be doing at this point. If you're, for instance, going to create a visit type called SFV, and they're going to create a visit type called SFV, how's your clinician going to know which one to use after midnight when that information is now live and they're using it in your real database? Are there plans and to create and provide dashboard and reports for HOPE? Because you're going to need to track this. Your QAPI is going to be very important to you, and you're going to need tools to assist with that. Those are specific questions you're going to need to ask and make sure that you have answers to. And then it comes to procedures. You want to make sure that you have a clear understanding of how your existing dashboards, analytics tool, reports are going to change with HOPE. And make sure you're asking for tracking tools that you may need. But again, you have to do a complete analysis of what you have today in order to do that. Prompts and reminders are very important. Where are they going to show up? Who's going to see them? Are they just going to be in scheduling? Are you going to be able to look at your timesheet and see how you're doing, how you're tracking with making sure you're compliant with that? But tracking in is great. But before all of that happened, how are you going to know that something is due? Where is it going to show up? Are there going to be alerts? Are there going to be notifications? And what are those notifications going to stay? For your clinicians that are doing SFE visit, is there a way that they're going to know which symptom they're following up on? Or is that going to not be significant or not be apparent in the software, and you're going to plan for that in some other way? Collaboration. Talked a lot about the questions that you're going to ask. You're going to hear more about that. But what do you have and how do you collaborate with your vendor? Number one, attend those sessions. Ask questions. Come prepared with questions based on your review of your processes and your procedures internally. Make sure that your questions that you're asking are clear. Make sure that you're as specific as you can be. Do not be vague. Do not ask, where is SFE visits going to show up? Do ask them according to the way that your software works. Ask them, is it going to show up on this screen, and this screen? Be very, very clear, because that's going to help you to lead your clinicians more effectively. Be open to exploring additional new features and functionalities that they will have. Please do not say, oh, we're not going to use that. Look at it. There's a reason they've created. It's going to have some benefits. Make sure it's not a benefit that you will need in the near future. Meet with your account executive. Know who your account executive is with your vendor. Set up time to talk to them, but make sure you come in extremely prepared for that meeting. Make sure that you understand if there are tools within this system that you have never used that you should explore now to be more effective in meeting the requirements of HOPE. Also, discuss ways in which they're planning to implement HOPE may not work very well for your business and your needs within your community. Make sure you've discussed that so that as you move forward, you'll be able to have a collaborative communication, and they'll help you identify how to navigate HOPE using their product. Share your implementation plans. It's not a secret. It's better if you work together on that. If you're planning a training that's going to coincide with something they're planning, have your clinicians show up versus you doing all the heavy lifting. These are tools that are available to you and come with your cost of your software, so make sure you're utilizing them. And then discuss with them any need that you may have for additional support and resources. You'll be surprised what they have. They're working with hospices around the country. They're learning from hospices around the country that are using your specific product. Help them to work for you and to be as effective and making you a winner in using their product. Make sure that you're discussing everything that relates to this implementation of HOPE within your organization. Keep in mind, nothing is off the table. The more you utilize them, the more you're going to be prepared for HOPE. Partnership is definitely a commitment. There is a lot of commitment involved. There is a commitment to be prepared. Your vendors are preparing, and they are actually scheduling a lot of sessions for you to attend. Please make sure that you attend. Talk to your account, or if it's not clear, ask who'd be best for you to attend that particular session. Make sure that you're also developing a stronger relationship, not only with your vendor, but with your staff. This is the time to make sure that you're presenting the benefits of using all the tools that you're provided within your organization to everyone that you're partnering with. HOPE is about quality. Make sure that all your stakeholders are planning and doing their highest quality work for success. Your vendor cannot be successful and they cannot plan very well for you if you don't collaborate, communicate, and remain committed to this journey. Everything you hear may not be what you want to hear, but definitely be participants in that. Make sure you're asking the questions, because it's not what I want to hear doesn't mean that I can't get it at a later date. if I continue to collaborate. Remember, that process never ends with deployment. It starts all the way over as they get feedback. They're committed to then starting with that communication and making sure they're hearing what's important to you and working on future release. Last but not least, do not forget to celebrate. Hope is going to be a journey. It's not a sprint, it's a journey. When you get to the first hurdle and you've actually hit that milestone, make sure you celebrate it and include your vendor in that. Tell them how you're doing. Tell them what worked well along with areas of growth, but tell them what you've accomplished and thank them for being a part of this journey with you. Now, Carla is going to take you a whole lot deeper and a whole lot wonderful more thoughts for you to consider as you continue on this journey.
Thank you, Donnette, and thank you, Judi. So we're going to talk about what can you do right now. The reality is you need to start right now. Don't wait until, September 20th and decide, how am I going to get all of this stuff together? So we're going to actually go through quite rapidly a process of maybe some of the things that you can do. First, a reminder, what should that transition look like? Starting 10/1/2025, you are no longer to submit the HIS data. It's not going to take it anyway. But remember, it's being replaced by the HOPE assessment data, which will be completed by RNs at specific times during admission and at the 2 HUV visits. Many of the components are the same, but there are additional or more components in the HOPE tool. It's for all new patients. All new patients will receive hospice. All current patients who were admitted prior to 10/1 will move forward and only receive the HOPE discharge. You won't do any SUVs. You won't do any HUV visits. It's only the discharge that you'll put in. Some people wonder, well, to get all of my current patients into HOPE, what should I do? Should I discharge everybody and readmit them? Please do not do that. There's no reason for it. We understand that there's this cutoff that's going to happen, and anybody who was on your service prior to midnight, like 11:59 on 9/31, those people are exempt other than the discharge. No HUV, no SFV visits for those admitted prior. Anybody admitted at 12:01 or after on 10/1, they're all going to have the HOPE admission and the HOPE discharge. If they're on service by day 15, they will also have had an HUV or hospice update visit between day 6 and 15. Remember, in the HOPE tool, the day of election or the day of admission is counted as 0. So if your software puts your length of stay and counts the admission day as 0, that's fine. But if they don't, then when you do an update, you will you do an update. When you look at, I'm sorry, I looked at the chat for a second. If you trigger your HUV visit based upon the length of stay, if day 0 is not the day of admission, you need to teach your staff day 7 to day 16. Then there's another HUV visit. If your patient is alive and still with you on day 30, you would have done the second HUV visit. And for some of your patients, you'll do both the SFV as well as the HUV. Okay. There are special circumstances that we need to be familiar with. If a patient is transferred from one hospice to another and it's within the same certification number, so in some way think of that as 2 different branches of the same company. As long as they're receiving continuous care from the same hospice, then you don't need to do anything different. If they were due for an HUV, you have to do the HUV. There's no need to change. Just keep on going with that. If the patient, because they're receiving continuous care, if they were from another hospice, so hospice down the street to another hospice in another state, then you do need to, there's no need to discharge and admit, but because your hospice didn't provide the care, you need to do the HOPE based upon your agency's care. So you do the HOPE assessment tool you do the HUVs. If a patient is discharged for non-timely face-to-face, or if you have like a Medicaid to Medicare payer change, then and the patient is on service without interruption during all of those days, you don't have to do anything different with the HOPE tool. If you've finished doing all of the HOPE submissions, other than the discharge one, you don't have to do an additional one. And if the patient is traveling and you're contracting with another hospice, there's no change in that HOPE timeline. They may or may not need to do an HUV visit and an SFV visit if indicated, based upon how long their length of service is. Some people, if you're discharging instead of contracting, if they're going to another place, they're leaving New York, which is where I'm sitting, and they're going down to Florida, which is where Donnette is sitting. And I don't want to be responsible for any care for them in case there's a problem on the way down to Florida. It's going to take them 3 days. Then you might discharge them. Then the readmitting hospice would have to do the HOPE tool starting with the admission date. Okay. Then why HOPE? So we're going to look at different components of HOPE implementation. And the first is staff education. Staff education is going to be vital. They need to understand why HOPE is important to them. It's not just another thing for them to do that's meaningless. It actually could be something that will help provide information that identifies opportunities to adjust practices and improve patient care. It will give us data that's going to be publicly reported to show potential consumers why you are the hospice that they should choose, or that they should choose hospice altogether. It will in the future impact our reimbursement. And if you don't get the 90% submission of the HOPE data with all of the visits required, you will have a 4% deduction for non-compliance in your payment rate. And it can incorporate data into your care planning process. If something is identified as a problem for the patient, that should go into your care plan. It's in your problem list. You need interventions. And there are things that, as we talk further about QAPI, if you identified a problem, you do the SUV visit, and when you go back on the SUV visit, your interventions were effective, and they now say, no, I don't have a problem with that. That's really valuable information, as valuable as if they said, yeah, I still have a problem with the same thing. What were your clinical practices and protocols? Why didn't you fix that? So again, it can be something that can assist in care planning. It can help us create best practices. It can help us identify those areas that maybe our clinical teams are not as strong in that we want them to be strong in. It can help align our visits to the patient's needs, and it can enhance care, as I just said. Okay. Staff education. When you know how the EMR is going to work, you're going to have, as Donnette said, you've got to educate them on that. Remember, it's not a nursing assessment. It's the patient's perception of how they were affected in the last 2 days by each of the symptoms, whether or not affected, slight, moderate, or severe. In fact, CMS has validated that it's not a nursing assessment because they've allowed LPNs to provide that, to make the SFV visits. By state licensure regulations and by Medicare regulations, although we love our LPNs completely, we do know that they're not able by licensure to do a clinical assessment. So that's why we know it's the patient's perception. There are new things added that the HIS doesn't have. It's all the HIS items in addition to living arrangements, availability of in-person assistance in the home, skin assessment with type and treatment, expanded diagnosis list, the presence of imminent death, what the preferred language of the household is, whether there's an interpreter needed, and whether there's presence of neuropathic pain. So once you've done your staff education, you should take a look. Your QAPI division, whoever is in it, should actually be looking at the HOPE tool. If the system that you have live, if HOPE was live today and you didn't make any changes, let's just say starting today, you're going to look at I didn't make any changes. If Hope was live today, what would I score? Like, what are my practices and processes? So you could audit 20 records today to see if there was in the assessment at the time of admission, whether any one of those symptoms was marked as having a problem. Then look at, was treatment initiated that would have, and did you trigger an SFV? Was treatment effective at day 2? Because that would be when the SFV visit would be. What did you follow up with? Was it a phone call? Was it a visit? Was it at the next visit, which was a week later? You asked the question. So see, and then also look at the time and the date of documentation of those visits and when they actually hit your system. Okay. QAPI can also, you need to review your QAPI plan. What are you going to add to your QAPI plan that you're going to audit into the future? The percentage of visits not made and reason why: refused, not at home, hospital. What are the majority of your visits? We didn't make an SFV visit because they weren't at home, as Judi said. Percent of timely completion of the admission, the HUV1, 2, and SFVs. Clinical documentation timeliness. Auditing the timeliness of submission and acceptance into the IQ system. And we're going to talk about submission at the end. Do you want to use this as an opportunity to initiate a performance improvement project for the implementation of the Hope tool? It's perfectly fine to do that. Do you want to pilot something? Do you want to take 2 RNs out of the field and say, I'm going to teach you how to do these Hope things, give them the tools and have them for every admission that they do in the next 2 weeks, have them actually go through the Hope tools that Judi provided with you and are in the resources at the end, and see how you would fare with that. Okay. You're going to have to take a look at your policies and procedures on documentation, on assessment, on the HIS if you have one, and on the Hope tool. What do you have to replace and put in? Many of us put HIS in our admission policy, so we're going to have to take that out and replace it with the Hope tool on or after October 1st. We need to look at our current assessment and our data collection to see if there are duplications. We want to see, once you understand from your EMR vendor, is Hope tool a separate form that they finish the assessment and then go there? Are there links so that they answer the, do you have neuropathic pain? Yes, no, here in the assessment, and it floats over or links in. You can tell I'm not the computer one, the EMR vendor one. So how will that all work? If you have a lot of places in your EMR that you have duplications, can you get some of those out in advance so that as you're adding new things, you're not making a much larger assessment tool? Look at your documentation completeness timelines. If you allow 48 hours to document, and then they document and then they sync and then it goes in, will you actually miss an SFV visit? Especially if that clinician is not the one who's going to do the visit. Will you actually get the information that says we need to launch an SFV visit, but it's outside of the timeline already? Again, real-time documentation is the goal here. I already said, is Hope embedded in your assessment? Is it a hybrid? You're going to have to look at your policies around that. And then what information will you add to your patient admission information? So a lot of us have patient admission information. We welcome them to the agency. We talk all about how that the EMR is vital to clinical coordination and communication. Do you want to put something in there that explains that there are certain visits now that we have to do within a timeline if there's a symptom issue, so that you'll have less people who are going to say, I couldn't find the patient, I couldn't do the SFV visit. Okay. So from a symptom management perspective, this is an ideal opportunity to look at how good you really are in all of the symptoms that are listed in the HOPE tool. And those are really things that the patients are really concerned about. And we as hospice clinicians want to make sure we're at the top of our game. So what's your current practice when a patient has a symptom that would have been moderate or severe based upon how it affected their life? Do you visit the next day? Do you call the next day? Do you visit within 2 days? Remember, HOPE is going to make you, to be compliant, visit within 2 days. What should yours be? What is yours and what should yours be? And when can you start that if you're not where you want to be? And then what's your definition to determine slight, moderate, or severe when the patient rates that? So there really isn't any clarification other than have the patient rate not slight, moderate, or severe. It's not a nursing assessment, although nursing assessment will, of course, be part of the conversation, but it really is the patient's perception of how this symptom has affected them. So all of that needs to be part of the conversation. Then what are your order sets right now, and are you going to have to change them? So you should at least have two PRN visits for symptom management in the first month of care, because you have a potential for 2 SFV visits, actually 3 SFV visits during that time, one from the admission assessment, one from HUV1 and HUV2. So do you want to hard code those in so that the nurse isn't creating new verbal orders? Then what education practice updates to achieve relief at the time of the assessment visit? So the SFV, remember, asked since the last symptom impact assessment was completed or at the time of admission in the last 2 days, how has the patient been affected by the following symptoms? Our goal would be that if we identified at the admission or HUV visits, that we would initiate treatment with a physician's orders, and we would make sure that that patient had relief so that when we went back for the SFV visit, and again, we say, how was it in the last 2 days? That they actually say to us, it was pretty good. I would say slight to none. Then that shows that your actual clinical practice is improving the care. The goal is that we have it's a lot better, and we're tracking it. In fact, as part of QAPI, that would be one of the measures that we should be looking at. Now, if you receive orders and it takes you 4 days to get orders, then you've got a clinical practice issue, and you can identify that and deal with that. Okay. More about visit frequencies. Do you visit 7 days a week? You're going to have to if you don't. There will be times when the HUV wasn't done during the week and you're going to end up having to do it on a weekend, or it's going to trigger, you do it on Thursday and it's going to trigger a Saturday visit for the SFV. So one of the questions we keep getting is, will visit frequencies increase because of these additional visits? It maybe not. If you align your visits to that, it actually might not increase. It might be the number of visits you're doing now. What I'd ask you to do is look at what your visit practice is, and all of the administrators are going to say, well, we generally, we visit based upon the needs of the patient. But get down a little bit further, down to the staff level. You likely have some of the nurses, or at least I know I used to have some of the nurses that had Monday, Wednesday patients and Tuesday, Thursday patients. And Friday was wrap up for anything else that comes along. We need to still get away from, I always visit my patients this many times a week. It's based upon need. Can your current orders be aligned to the HOPE timeline? You need to take a look at that. Will you need more PRNs for symptom management, as I just said? And will visit lengths of time increase? The admission has almost twice as many items now with HOPE than the HIS required that the RN has to do. So we might see depending upon how the EMR helps us, we actually might see a little bit of an adjustment in the amount of time it takes to do an admission. Other visit frequency considerations, will your current orders be sufficient and will length of time of visit increase? I'm thinking new admissions might increase a little bit, but keep track of that sort of thing. Here's an example of how you can get into trouble. So the patient was admitted day 0 on Wednesday the 1st. That's the 5-day window to complete the admission. The blue is the window, the 9-day window for HUV1, and then the yellow is the window for HUV2. So the nurse visits on, again, you have a couple of days before the RN has to visit after the election. They elected on the 1st. Your RN visits on the 3rd, and your RN says, unusual patient, things seem like pretty solid. I'm just going to visit this patient every 2 weeks. So she or he puts the next nurse in visit on the 17th. What happened? You actually missed the HUV timeline. So now you're delinquent in doing this HUV. So again, this is just a quick example of how practices are going to be different and change. I know we're running out of time, so I'm going to go a little bit quicker. Let me paraphrase this. This is an example. On an HUV visit, the patient says, hey, I've been so nervous in the last couple of days. I just don't, I can't even do the things that I want to do. And they said it was overwhelming. Their anxiety is overwhelming. You note that they have anti-anxiety medications and you say, well, have you taken this? And they say, oh, I didn't know what that was for. You've all been there. So you say, well, let me give you some education on this medication. The nurse does that. The patient takes one. The nurse calls them back a couple of hours later and they say, that was like a miracle. I feel so much better. Would you initiate? How would you score the anxiety? It would be a moderate to severe because the patient said it interfered with everything I wanted to do. I'd rate that as a severe. Would you need an SFV? Two hours later, they were perfectly fine. The answer is yes, you need an SFV. Fortunately, when you go out for this SFV visit, you will be able to say slight to none because you fixed the problem for them. Now, almost the last question, can you prevent an SFV visit, follow-up visit from happening? If you treat in the moment, you still can't prevent it. If the patient on admission, it's a look back for 2 days. You couldn't have prevented that one if they say moderate to severe. If on the HUV visit, if they say moderate to severe, I think you might have been able to prevent them by proper symptom management, really focusing all the time that you have the patients on service. If you have good clinical protocols that when you identify something that it gets treated very rapidly, by the time you show up for the HUV visit, you may have actually taken care of the problem and it's going to be, I don't have anything that is moderate to severe. And education of the patient to say, call me if there's a problem with a symptom, instead of waiting for you to show up for the next visit. And that happened to be, of course, an HUV visit. And you're going to have to say moderate because they say it's impacting my ability to function today. So you can take a look at that. You might be able to prevent some of those SFV visits. And wouldn't that be why we're in hospice and what our patients expect from us anyway? Okay. Then my last slide is data submission. So don't think that HOPE is just for the clinical team, the referral center, the clinical team. It actually is for anybody who's currently doing the HIS submission. Are you going to continue to have them do that? What education do they need? Remember, there are those 4 submission points. And I know that somebody asked earlier, when do we submit the symptom follow-up visit, the SFV? And it's if it was identified at admission, the admission submission is going to include the SFV information. Same thing on the HUV1 and HUV2. It all goes into it. goes in together at those three defined points of time. And you have 30 days for the submission to be sent in and accepted by the system. If you don't, then it becomes a problem for you. It becomes a negative entry. Hospice uses the queues, and I'm saying it wrong, but the queue system for HOPE submission, for the HIS submission. We're going to have to migrate over to the IQs for the HOPE submission. The information will be available for us on how to do that sometime in the summer of 2025. It's not there right this minute, but if you're billing people, the people who are going to be doing this really want to know how to work within IQs and you're not part of a home health agency, there is in the resources or references section, there's the bottom one talks about a link to CMS talking about how the home health migrated over. So that might be helpful for you. Also, there will be a validation tool available at some time this summer so that you can test your responses in advance of actually submitting them. Here is a list of and links to all of the references, or most of the references. There's more on there. As Judi said, there's a ton of information. There's a lot of YouTube videos from CMS accessible on through the CMS website that you can use. So we encourage you to start looking at those things now. Okay.
Well, that brings us to the end of today's very informative webinar. Huge thank you to our incredible panelists, Judi Lund Person, Donnette Threats, and Carla Braveman for sharing their expertise and valuable insights. Your guidance on HOPE readiness is truly appreciated, ladies. Seriously. We also like to extend our gratitude once again to our sponsors, Confidence Consulting and HospiceCorps, for their support in making the discussion possible. And of course, thank you to all of you for joining us today and for your engagement in this important conversation. For those of you who submitted questions in the chat, we didn't have time to address those, unfortunately, but don't worry, we will follow up with those via email. And if you have questions that have come up after and you'd like to separate that out, please use the email address that you see here and submit those on or before the end of business on March 25th. We'll be sure to get out those responses to you. We're also excited, lastly, to share that we will be hosting part 2 of our webinar series, HOPE webinar series in April, featuring a panel of leading hospice providers. So your leaders will be represented, and we will discuss their strategies and insights as they prepare for HOPE internally. So stay tuned for more details on that. Again, thank you all for your time and participation today. We look forward to continuing this conversation and supporting your efforts in preparing for HOPE. You guys have a great rest of your day.